Hi, everyone. Welcome. I know everyone is just joining us and getting settled. Thank you all for joining us on this spooky week for a little continuing education. Just going to give everyone a minute to join us. Maybe you want to find somewhere comfortable to sit. You want to grab something you want to take some notes with, get a little snack, maybe some water. Hello, thank you so much. I'd love to hear where everyone else is coming from. I'm in the Bay Area. Dr. Weissman is in Red Bank, New Jersey, and excited to chat with everyone this evening. Awesome. We've got Oregon, Maryland, Connecticut, New Hampshire, Texas, Arizona, Illinois, Ohio, New Jersey, Philly. That's where I'm from. Have to give a shout out. My gosh, it's coming in now. I love it. Minnesota, South Carolina, Texas, New York, Indiana, San Diego, Illinois, Arizona. It's so fun. Thank you all so much. Yay. Western PA, Canada. Yes, I love it. A few Canada. That's so cool. Did I see Alabama? I love it. This is amazing. Thank you all. Very cool. Well, very cool. Mary Beth from New Jersey, MV from NJ. I love that. Awesome. Thank you all so much. This is so fun. Well, as I've said a few times, my name is Madison Alig, and I'm the VP of Clinical Relations at Radimal. And I'm so excited to kick off the spookiest session we've ever had of Radimal case rounds today. And so at Radimal, we come across all kinds of radiology cases every single day. But tonight, we're going to share some of our more twisted and ghoulish ones and some of the fun cases that we've seen of recently. And the focus tonight will be on small animal GI radiographs. And so you'll get to see how, in combination, our AI initial assessment tool, in collaboration with full consultations from board certified specialists such as Dr. Weissman, how that combination together allows for more clarity and better clinical decisions and outcomes. If this is your first time meeting or being introduced to Radimal, we are a leader in veterinary diagnostics. We combined a web-based PACS where we store all of your images for you with that AI initial assessment and triage tool, like I mentioned, and board certified consultations completed by radiologists, cardiologists, dentists, and more. So you're always able to get fast and reliable support for your imaging 24 hours a day. And so if you do have any questions about Radimal or interested in signing up, you'll see throughout the webinar, there's going to be a QR code at the top left corner of the screen that will allow you to create your free account and get your first 5 specialist reports for free from a doctor, again, like Dr. Weissman. And then from there, before we get started, some general information. This is a RACE-approved session, and you will get all of your certificates via email in a few days after this session ends. So if you don't see that show up this evening, don't worry. Just give us a day or so, and that's going to come into your email address. If there are any other questions, please pop them in the chat. I'll be watching throughout the session. And I'm going to send it over to Dr. Andrew Weissman, who is our co-founder and our chief medical officer. Thank you so much.
Hi, everyone. Like Madison said, I'm Dr. Andrew Weissman. I'm really excited to be here with everyone tonight, and thanks for joining us on a Halloween week. I know it's a often busy and exciting week for everyone, so thanks so much for taking the time to join us. Just a little introduction about myself. I am a co-founder of Radimal. I also work in clinic as a radiologist at Red Bank Veterinary Hospital in New Jersey, as well as being a teleradiologist. I also serve on the DEI and AI committees at ACVR, which is the Radiology College. And like Madison mentioned, we've got those QR codes in the top left. Anyone who's a new client, you can scan those, and those will have 5 free radiology reports. Before we get started, I just kind of want to set out the plan for the evening. We're going to go over a few cases. They are all GI related. And so we're going to be talking mostly about small intestinal mechanical obstruction and linear foreign bodies. And one of the things that I want to kind of impart to you is that while there are going to be like quote unquote answers to these cases, the one of the things that I'd really like everyone to take away from this are what are the kind of cues that we look at when we're deciding is something obstructed? Is there a linear foreign body? Right? Because those are pretty big decisions. Oftentimes, we're sending these cases to surgery. And so I'd really like to talk about some of the ways that we um, use kind of these radiographic findings that we're going to identify to make the clinical assessment of the patients. And then additionally, I just kind of want to cover that these cases that we're talking about, both mechanical obstruction, linear foreign bodies, are very complicated cases. It's not like when we're talking about left atrial enlargement and I can point to the left atrium and in every case the left atrium is in the same place and we can really hone in on exactly what it needs to look like. There just naturally is a lot of variation in these cases, both in terms of maybe where the foreign body is located, can we actually see the foreign body, what are the secondary effects of the foreign body, and that's why really to master these types of cases we kind of have to work on what are we going to look for and also allow ourselves a little bit of grace in that we're not always going to get it right. Even radiologists, like if you were to show these cases to a group of veterinarians including radiologists, you would get a variety of different responses. Um, and so I think that's important to remember both when you're in clinic making a decision yourself and maybe when you're sending things out to Telerad. You may get a report back that's like a possible obstruction or possible linear foreign body, because sometimes that's the most that we're able to glean from radiographs and we need additional imaging like an ultrasound. Or maybe on Friday night, the radiographs were non-obstructive, but on Saturday they are obstructive because, as we know, diseases are dynamic. And so that's just kind of one of the caveats to these types of cases. So I encourage you, if this is a type of case that you're working on or you feel like you're not as good at as you'd like to be, join the club. They are very challenging cases. And so with that, let's try to learn some things tonight. Case one is Bella. So it's a 4-year-old golden doodle. She's presenting for vomiting. The way these cases are going to work, I'm going to show you laterals and then VDs. I'm going to give you guys like a minute or two to kind of look at them. And then we're going to have you vote. And so your voting options, you're going to put it in the chat, are going to be whether you would send this dog to surgery for a small intestinal mechanical obstruction, send it to surgery for a linear foreign body, want additional imaging like an ultrasound, or you're going to treat it outpatient. So those are going to be your 4 options. They'll all be listed on the next slide. Just wanted to kind of give you guys the plan. So just take a second, look for yourself, and then I'll show you the VD in just a second. While you're looking at these, some of the things that I kind of ask myself are, is there material in the stomach? Is there material in the small intestines? Is there distension? Is there plication? How's the serosal detail? Those are sort of things that are kind of running through my mind. I'm going to go ahead and go to the VD.
We're getting a few answers so far. Thank you, everyone, for being brave and sharing your thoughts. We have need
Yeah.
ultrasound, mixed gas pattern, question mark, send explore. One ultrasound, looks suspicious in small intestines. X lab, ultrasound, ultrasound. Surgery, B linear, ultrasound, ultrasound or explore if not available.
And I would encourage you guys like physically put your what you think in the chat, because it's very easy when you're thinking in your own head. You're like, well, I think it's B, but then you see like as we go through cases, you're like, no, 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 I knew it was A, or whatever the case is. And so I'd really encourage you, like, there's no risk here. We're not, monitoring what Kathy in Mississippi said. So please, put your answer in the chat.
Thank you. We're
Kathy
getting
from
linear
Mississippi, if you're
corn.
here, I wasn't picking on you.
Thank you, Kathy. Barium series, a lot of ultrasound. Definitely, we're getting a few repeat rads with fluids, but I've several number B.
Great. While people are just putting in their votes, I just want to say one thing. I apologize when I did this. It's in the correct orientation here, but on this middle one, this VD is actually flipped, just so you know. But I wanted to comment, someone mentioned a barium study, which is a great thing to just touch on while we're all thinking about this case. Barium studies certainly have a place in imaging. I would say by and large, if you live in a geographic area where ultrasound is in any way possible, even by referral, I would absolutely recommend that over a barium study. To do a barium study appropriately, you really have to tube the patients a very large volume of barium. And then if they end up having to go in for surgery, as you may know, if you've done a barium study, it can be a really tricky situation to not have barium leakage. And even if you're using something like iohexol that is less irritating to the mesentery, it still can be quite challenging and certainly time consuming for your technician. So if you have ultrasound at all available, I would absolutely recommend that above a barium study. If you live somewhere where that's not feasible, by all means, a barium study is a great idea. Okay, so it sounds like, Madison, we've got a lot of B's, but certainly a bunch of other thoughts, especially like repeat rads, ultrasound, like that. Is that about accurate?
Yes, I would say a lot of B, a lot of C. And then one person mentioned the importance of having more details on symptoms and history. Another more specific response we saw, and please bear with me, I'm the only non-medical professional on this call, probably, but reduced serosal detail and dilated SI.
Perfect.
Yeah, but I think a lot of ultrasound, it seems. And someone also, a few comments of, I don't see good diagnostic quality films, retake, question mark.
So, whoever mentioned more history, 100%. All I know is vomiting. And if you are one of the people who sends RADs out for a teleradiologist consultation, more history is always great. I would love to know, when was the last time the patient ate? Has it vomited once? Has it vomited 12 times? Did it vomit 12 times today? Like, those kind of details do really go into making an assessment about whether to send a patient to surgery. And whoever mentioned that these RADs are not ideal, I don't disagree. These are real RADs that Radmil received from one of our clinics. And so oftentimes, this is the best that the clinic was able to get, whether the patient wasn't sedated or wasn't cooperative, hard to say. But I agree, the quality is good, not great, could be better. All right, so when you feed your RADs into Radimel, meaning after they're taken on your X-ray machine, you will get back an AI-generated report. So like we talked about, linear foreign bodies, mechanical obstructions are going to look very different in every single patient. And that makes them very challenging to identify with AI because they are so different from patient to patient. So the AI is very good at identifying things like gastric material. So the AI is identifying gastric material. It's also identifying some intestinal distension. You can see in that middle image here, and it's going to highlight some of the areas. And then it's showing a small intestinal mechanical obstruction, and it's identifying it here. It's saying it's detected it in 2 images. And so that kind of is helpful. If it's detecting it in 1 image, I'm sort of like, did the AI really see something? You can see it's detecting gastric material in 5 images. There actually were more images. I just only showed you the ones that we kind of needed to see for this case. And so based on the AI, the AI is predicting that we have gastric material and it has a concern for small intestinal mechanical obstruction. I'm going to kind of hold this spot here because we're going to go to the next slide. I'm just going to go back. That was on the right lateral. So it's showing this spot right here as the potential for mechanical obstruction. So this is kind of the way I approach these RADs. So number one, is there stuff in the stomach? One, based on the AI, it seemed pretty likely that there is going to be gastric material, and I agree. I think it can be hard on each individual view to make that assessment, and so I use all of the views. So for instance, again, my apologies, this should be flipped. Here's gastric material in the fundus of the stomach on the left side of the patient. On this left lateral projection, there's a little bit of soft tissue opaque material in the stomach here. And on the right lateral, we only get a little bit of stomach, and I'm not convinced that there's anything there. But in general, yes, we have gastric material in a vomiting dog, definitely concerning. In and of itself, not going to be a reason to go to surgery. The next thing I want to ask myself, are there 2 populations of bowel? That's one of the things that we're going to need for a mechanical obstruction. Are there 2 populations of bowel, one of which is markedly distended versus the other? There's ways that we can measure the bowel, and I have a slide at the end that details it so that you guys can have that information if you need it. And so I'm going to go ahead and grab my pen. And so I want to remind you, when you measure bowel, you're going to measure it against L5, the body of L5. So it's going to be about that. I unfortunately don't have a ruler in the Canva, but what's more important is that you know how to do it. And I'm going to go ahead and pick this one that the AI highlighted and draw it like that. What I want you to notice is not only did I measure the bowel, but I measured the thickness of the wall. You can see here's lumen, and then here's the bowel wall itself. It's really important that you include the bowel wall when you're measuring bowel. And I think that this measurement, so it should be, as you approach 2, that makes the sensitivity and specificity higher for a small intestinal mechanical obstruction. I can tell you I measured this before, it was about 1.7. So not quite at 2, but getting there. So I'm a little worried about the possibility of a mechanical obstruction. Then I want to ask myself, is there a linear foreign body? And for linear foreign body, I'm looking for things like angular gas opacities, that paisley appearance, comma-shaped gas opacities, plication. And the thing that stands out to me the most is this bowel here. I can kind of see there's like this undulating gas and soft tissue opacity of it. Um, I also see it a lot in this area right here. So we've got some of these like angular shaped gas opacities. Here again, this gas opacity itself is quite angular. On this VD, I have to be careful. This is cecum, so I'm going to ignore that. It's possible this is cecum, but I'm just not sure. Anything in the area of the cecum, I'm just going to ignore. But these kind of angular gas opacities here are pretty convincing for me for a small intestinal for a linear foreign body, a small intestinal linear foreign body. Anytime I have a linear foreign body, the next question I want to ask in my head is the serosal detail adequate? Because we know that linear foreign bodies can perforate. In this case, I think that the serosal detail is normal. I'm kind of looking down here in this area, and I can see normal fat opacity compared to soft tissue opacity, and that distinction is very clear. And so this patient has a small intestinal linear foreign body and gastric material. We know that oftentimes linear foreign bodies are anchored in the stomach. I don't definitively see that in this case, but there is gastric material, so it's certainly possible that there's foreign material and a linear foreign body, or that this could be residual food that just hasn't emptied out because maybe the patient has ileus. If you are not sure if this is a linear foreign body, certainly you could medically manage and repeat RADs. Anytime you have a concern for linear foreign body, we are going to want to be more aggressive, both with medical management and with repeat RADs. I definitely wouldn't wait more than 8-12 hours max to repeat RADs for a linear foreign body. A mechanical obstruction, a foreign body, that can sit a little bit longer, but these linear foreign bodies, because of their risk of rupture, are certainly more concerning. And so if you have those concerns, I would send those RADs out to a radiologist. I would stack those RADs. I would refer the patient for an ultrasound, or I would aggressively medically manage the patient and repeat RADs in 6 hours, 8 hours, something like that, 12 max. But I also am hopeful that as you guys get better and more confident in looking at these cases, this is a case that I think you could look at, evaluate, and identify as a linear foreign body and send to surgery. If you were uncertain, let me get rid of these get rid of these. 1 second, let me erase that one. This one, okay. If you were uncertain and you sent this case to Radimal for a radiologist interpretation, I happen to have read this one myself. So I'm just going to read you what I wrote for the gastrointestinal tract. The stomach contains a moderate amount of granular soft tissue opaque material, which we talked about. Multiple small intestinal segments contain granular soft tissue opaque material with angular gas opacities and undulation of the serosal margin. There's no small intestinal distension. So this is one of the hallmarks between a mechanical obstruction and linear foreign body. And over this talk, that's kind of what I'm going to drive home. They're two distinct entities, a small intestinal mechanical obstruction and a linear foreign body are two totally different things with different radiographic findings. A linear foreign body, we're talking about plication, angular gas opacities that does not have to have distension. A small intestinal mechanical obstruction has to have two populations of bowel. And so the fact that this linear foreign body does not have intestinal distension makes total sense because they don't need to. And then, because I felt confident in this case and in the plication, I was able to conclude small intestinal linear foreign body. I'm wondering if one of the images that was left out let me feel like it potentially was anchored in the stomach, because just on these alone, I don't feel particularly strong about that, and recommended a surgical explore. Again, this is, I've been a radiologist for 10, 11, 12 years. And so these are challenging cases. So if you were unsure, totally fine. That's why we're here, to learn and get better. The other thing I just want to point out, if you're new to Radimal, is these reports might look a little different than you're used to. The first page has kind of a summary, a bullet list of the findings. And that way, if your technician is, getting the reports, if your owners are looking at these reports, they're able to, at very quick glance, identify what is the problem for this patient, and, start treatment, whether that's, start a estimate for surgery or referral, whatever your case may be. But that's kind of the way all these Radimal reports will be set up. Does anyone have any questions about these RADs before we go on to the next case?
I
Think
think
we're
we're
good to
okay,
go,
Andrew.
Madison?
Thank you.
Wonderful. All right, let's go to case 2.
I
Frank,
spoke too soon. One moment, of course.
of course.
Reduced serial detail. Is this a
Mhm.
concern?
So reduced serosal detail in this patient, I think,
Oh,
looks
excuse me.
normal. You're totally fine. um, it absolutely is something you want to look for. I think in this particular case, we have fat opacity, soft tissue opacity. So we at least don't have a large amount of effusion. If we want to talk about in the mid abdomen, is there slightly decreased serosal detail? Potentially. If I look at this segment, I can see the gas-filled lumen and I can see the wall there, but in here, maybe a little bit less. And so it's possible, like if you were to ultrasound this dog, maybe there's a little bit of either scant effusion in the region of the linear foreign body, or potentially a little bit of peritonitis. Those are, I don't want to say expected, but not unusual in a linear foreign body. What I want to make real sure of, though, is that there's not like pure effusion, like enough of a volume of effusion that we're seeing it elsewhere, because that's when we start to really worry that something has perforated. It's not uncommon that in the area of the linear foreign body, you might have a little bit of peritonitis just from focal inflammation. Hopefully that answers your question.
Uh, they wrote peritonitis was what I was concerned about. Thank you. Two more questions I have. What was the linear foreign body? And second question, is it normal for there to be no mention of the spine on these reports, even if not a reported issue?
Good question. So, um, me personally, I organize my reports by body system, and so I have musculoskeletal. Um, I think it's tricky because as a radiologist, we're kind of walking a fine line between. Well, let me back up one step. We're always looking at everything, whether the dog is vomiting or the dog has bladder stones. Any radiograph that is part of a study, I'm looking at every single anatomic structure on every image. What becomes challenging is, how do I then put that into a report? Because if a report is filled with the spine is normal, the pelvis is normal, the stifle joints are normal, the soft tissues are normal, eventually it gets to a point where it's like hard to figure out what maybe isn't normal. And I find that the reports lose a little bit of their value. So I personally, and I think this is something every radiologist struggles to strike a balance with, I personally kind of just list the big things that I think people are mostly worried about. If this dog had spondylosis or degenerative change of his hips, I would include that here. But you're right. I do not specifically mention the spine, just like I don't specifically mention the stifle joints. And that is, it's something that we all kind of struggle with because we want to assure people that everything has been looked at while providing a meaningful report.
Thanks.
And I'm,
Oh,
go
can
ahead.
I just interrupt for one moment? Just
Mhm.
wanted to emphasize, Kathleen, that bulleted list that you see on the left side of the screen, this is generated by Dr. Weissman. So essentially, this is a bulleted list that summarizes the findings that he has then written on the text side on the left side, excuse me, the right side of the screen. So you do have sort of that summary on the left and then the text also on the right. Um, and so just wanting to make sure that that's clear for you.
Thank you. And so you're right. So it's very well marked which are the AI generated reports and which are the radiologist reports. So it says AI generated report and it says here, this report is AI generated because we don't want there to be any confusion. These are things that the AI is saying, hey, these might be present in your patient, which is different from the radiologist reports. I, as the radiologist, am able to, like, I am singling out those disease processes as saying this patient has gastric material, has a linear foreign body. If I was uncertain, I could change this to say possible linear foreign body or something like that. So these are fully generated by a radiologist. Thank you.
And I
And
think
Madison, I
also,
think the,
oh, good.
oh, go ahead.
Wanting to just go back and just say what was the linear foreign body was the other
Yes,
question.
thank
And
you.
then
I couldn't remember
my
what it was.
my last piece I just wanted to also mention is anytime you do have a question about a report, the other thing that's nice about Radmal is we have a built-in chat feature, which is monitored 24 hours a day by a real person. So this is where you're able to continue to receive report from a specialist or one of the support team anytime, exactly for a question of like, hey, I just got this report and I have a concern about the spine. Could the specialist comment? That's exactly where that is available to you.
Absolutely. And certainly if you have questions, like, if the patient has back pain or you're seeing something in the spine and you're like, it's probably normal, but I'm not sure. If you write all that information, it's so helpful. Like obviously, maybe not obviously, but before I read any report, I'm going through the case history. And so if it said, currently has possible back pain, then I might be more apt to say the vertebral bodies are unremarkable, no evidence of, intervertebral disc disease, disco, et cetera. So definitely the more you kind of let us know what your concerns are, the more we can comment on it. And I believe that this case was a rope toy, pieces of rope from the rope toy. All right, let's keep going. Frank is a 7-year-old English golden retriever, vomiting and has a history of eating things he shouldn't. And so we're going to do the same thing here. We've got laterals here. Give everyone a minute to look at them. Here's the VD. And if anybody needs more time, like you want the closer up images, just, put a little thing in the chat and I'm happy to go back.
Okay, I'm receiving lots of A's, a couple C's. I do see two populations of bowel, so A, mechanical obstruction, question mark.
Let me know, Madison, when you think we've got most people's votes in.
We have mostly A's, and then we have someone wrote something which we'll see how I pronounce this. Pneumocologram. Wasn't so bad.
Yeah. Okay.
I'd probably manage medically and recheck x-rays in 12 hours. Long mechanical obstruction, dorsal abdomen. Mostly A and C, a handful of B's.
Love it. All right. So let's
Great.
start out the same way with this AI generated report. Excuse me, AI generated report. Again, it's going to tell us right at the top here, this is AI generated. Kind of like we talked about before, the AI is really great at identifying gastric material. It identified it in all 5 images. So that's something that I know that the AI is seeing repeatedly. That makes me feel more confident in that AI finding. You can see the AI picked up on something like spondylosis, which for the purpose of this talk, we're going to skip over. The AI is identifying things like colitis because the colon has a lot of gas in it. Gastroenteritis because there's mixed gas throughout the intestines. And then it's identifying a small intestinal mechanical obstruction. And it's kind of showing us right in this area, caudal to the stomach, where it sees it. So let's go back to our images. So I want to kind of go through the same exact thing we did the first time. I always start with gastric material. Is there gastric material? The AI predicts that there is, and I concur with the AI. Again, if I'm only looking at this right lateral, I'm like, I don't know, there's a little gas in there. I'm not convinced there's gastric material. On the left lateral, I'm not even 100% sure. Like, this is pylorus. Oh, and this is a great time to mention, let's talk about gastric, excuse me, take a quick sip of water. Let's talk about gastric positioning on radiographs. So on the right lateral, the patient is right side down. And so fluid is going, the patient is right side down, and the pylorus is a right-sided structure. So the pylorus is going to have fluid in it, which is why the pylorus is fluid filled on the right lateral. Left side down, the pylorus is up. That's why the pylorus has gas in it. One thing just to like remind you, on the right and the left lateral projection, the fundus is always up here and the pylorus is always down here. That doesn't change. The only thing that changes is whether there's fluid on the right lateral or gas on the left lateral. Okay, so back to the question of, is there gastric material? On the left lateral, I see a little gas. On the VD though, I see some material in the stomach. So in this case, I'm really glad that we have this VD view because that's the only one where I can definitively convince myself that there is gastric material. Next, I'm going to ask myself, are there two populations of bowel? So I know that this one is the one that stands out to me and is the biggest. This is going to be colon. I can see it kind of going to the pelvic inlet. And I think that's going to be the same thing as this one, which is traversing here. In an ideal textbook world, the colon would come up, would come across the transverse colon, ascending colon, here's cecum. In this one, the colon's kind of taking a different path, and we're just going to have to adjust to it. They don't always read the textbooks, as we all know. At first glance, I'm kind of looking at all these intestinal segments and thinking to myself, they're not very big, right? Like they're gas filled, but it's a uniform population. There aren't any that are massively distended. And if I were to measure against L5, 1, 2, 3, 4, 5, is this 5? Is this, I can't quite tell. I think this is 13, 1, 2, 3, 4, 5. So if I measure against the height of L5, there's certainly not going to be 2 times the height of L5. And so at first glance, I might think like, there isn't really anything here. And I want you also to imagine if you only took this right lateral and this VD, that may be what you think. This is my time in the presentation to put a plug in for taking 3-view abdominal radiographs. Always. It takes very little additional time for your staff to take an additional view. And because we're using digital, there's really like not a lot of increased overhead as far as cost. So what the left lateral allows us to see, one is pylorus, which in this case is not super helpful because I really need the VD to see the pyloric material. But what it does allow us to see really well is this textured, linearly textured soft tissue opaque material. We can see it on this right lateral too. It's just not nearly as well defined. And I don't know why that is. Like there are plenty of cases where on the right lateral, I would have read a normal abdomen, and on the left lateral, you can see a very well-defined, like mineral opaque foreign body. And so I don't have a good reason for why that left lateral oftentimes shows foreign bodies better, but it just does. And so I hope that everyone can see this linearly textured foreign body. And I know that it's not colon because on this one, this is colon. And so if this is colon, this can't be colon. The other thing that I think is interesting is if you trace it, you can actually see it going right into the stomach here. The other thing that's helpful about the left lateral projection, and this is just something that will come with more experience, on the left lateral projection, this is the path of the duodenum. This is where the duodenum lives on the left lateral projection. Fundus to pylorus, it kind of loops back up. This is duodenum. If we look on the VD view, I don't see the textured material very well. Like if I only had this, I would be very hesitant to call a mechanical obstruction here. And so it's really this left lateral projection that makes me feel very confident that there's foreign material here. And if I were going to measure,
Andrew, I'm just going to interrupt you one moment. I have two
sure,
questions. Can you outline the stomach? Can you show the close-up?
yes. So
Uh,
outline the stomach is challenging because it's not very well defined, but I can try. So here's stomach here. Pylorus is here. And actually, hang on, let me switch to, let me get rid of this. I'm going to use something that disappears so that I don't have to. Okay, on here, I don't actually know where stomach is. I'm going to guess stomach is here and pylorus is here. And on the right lateral, stomach is here-ish. Let's see. Can I show a close-up? Madison, if I come out of this and do a close-up, will they be able to see it?
I don't think so.
Okay.
I think
Well,
that you can zoom in on your own screen yourself. So you can zoom in on the Zoom and then be able to look into this, kind of like you would on a phone. I mean, just zoom in your screen.
let me do that.
I mean, to our participants. Thanks, Andrew.
Oh, thank you.
Yep.
Um, and so
Or if the it's Command plus, just so team our again our members
great,
know.
thank you so much.
Go ahead.
And so if I were going to measure, I'm going to measure the length of L5 again, and I'm going to measure, remember, I'm going to measure the wall here. I'm not quite sure that technically speaking, that is twice the height of L5. And so this is where we really need the clinical history to come into play. So I have an animal that is vomiting with a foreign body in the duodenum. That in and of itself is enough to send a dog to surgery. We will have something to take out of the dog and hand to the owners and say, this is the reason your patient was vomiting, and that is enough. However, if this patient was not vomiting, if these people did not have a lot of money, the stomach is not massively distended. This cloth material is not twice the height of L5. Like that intestinal segment is not twice the height of L5. It's not three times the height of L5. It's not massively distended. I think it is at least a potential that this material could pass on its own, right? It's not a linear foreign body. It's a small intestinal mechanical obstruction. The patient is vomiting. We have a foreign body. Going to surgery is absolutely 100% a reasonable thing to do, especially since the patient is vomiting. I'm just talking about in a scenario where maybe the owners don't want to go to surgery. Maybe you're not 100% certain. You can't send it out to a radiologist, don't have ultrasound, whatever your reasoning is. The important point to note about this case is there is a foreign body, but the intestine is not massively distended, and the stomach is also not massively distended. And so, whether things are moving through a little bit or there's a little bit of movement, I think this would be a reasonable case to medically treat and repeat RADs 8 hours later and see if it's moved. Certainly, it could not move at all. It could move, further down into the intestine and still require surgery. I guess my main point is it's not, despite there being a foreign body, this wouldn't be a patient that I would say euthanize if the owners couldn't afford surgery. Any questions about like that distinction that I'm trying to make here?
We do have a few questions, but I don't know
Mm,
about that specifically, so we'll just give
that's
them a
okay.
moment. Okay. Few questions that I have for you. On the lateral view of the small intestine gas pattern is a repeated symmetrical diagonal pattern. Does plication look like this?
Okay, so I believe, let me go back to my little pointer guy. Okay. I'm guessing they're referring to this. And so sometimes we refer to that as stacked bowel. Stacked bowel, in and of itself, is not a problem unless they are distended. And so I feel like that's something that was kind of like drilled into us in school. Like if it's stacked, that's really bad. It's only bad if it's distended. And these are not distended. And I know that because if I measured it against L5, it would not be 2 times that height. If we're talking about like this area in here, I think this is cecum. So we're going to ignore it. And the thing that to me is different from this gas pattern to the case before is these are ovoid and round gas opacities as opposed to the other ones that were more comma shaped. Even if we go over here, like these are all quite round or ovoid, not comma shaped. I'm just going to go back to that other case real quick so we can kind of compare and contrast. Like these gas patterns here are really weirdly shaped. This is a perfect comma one. This is a perfect comma one. These atypical gas opacities are what make me think this is linear. Here's another comma shaped. This one like this, that doesn't worry me. This would like if I just saw ones that look like this, that's round, no big deal. This one here, that's an ovoid one, no problem. But it's these comma shaped ones that make me worried about a linear foreign body compared to these that are circular and ovoid.
Amazing. Okay, a few other questions. Can you point to the duodenum on the VD view?
Not easily. So we have fundus to pylorus. The duodenum should be coming down right here. And if you look very carefully, you can see these very thin striations right here. It's like a gas and soft tissue interface. It's really subtle, very hard to see. And that's really one of the reasons why I feel so strongly about doing 3 views. It's basically just giving you another opportunity to see the foreign body. Um, Again, I don't know why, like this ended up being a t-shirt. This is a huge foreign body, but really the only view that I would feel comfortable sending this dog to surgery on is this left lateral. I cannot see it on the VD. If I just had this, I would say there's material in the stomach, could be food or foreign, and I would repeat RADS tomorrow. If I just had this right lateral, I would say like there's something here. I don't know that I would feel confident enough to send it to surgery. And I would probably repeat RADS on this too. So I can't stress it enough. Take 3 views anytime you have a GI case.
Last question on this case. In the left lateral, what is the peculiar looking area in the caudal thorax?
Peculiar looking area, caudal thorax. So we've got cava here, aorta here. My guess is maybe you're looking at something in here, and it's probably a little bit of fluid in the caudal thoracic esophagus. Plus, there's just a lot of vasculature sort of just branching throughout there. Unfortunately, we don't get a better look at it on the VD, but I think it's probably just a little fluid in the caudal thoracic esophagus. If you had questions in real life, absolutely take chest rads. Um, and again, just kind of going back to this AI report, um, when you start to see this mechanical obstruction identified in 3 images, that hopefully will clue you into like, hey, this is something that AI is concerned about. If you're not sure, send that case off to a radiologist, potentially stat the case if you have, doubts about whether to send it to surgery. Here's the radiology report. Large gastric foreign body anchored in the pylorus, likely extending into the duodenum. Cloth material is considered. The radiologist felt that there is potential intestinal plication. This is a great example of like, I don't read that case this way. I don't know I believe that there was not any intestinal plication in this case. But more importantly, my point is these cases are complicated, and different radiologists will have different opinions. And so we're all just doing the best we can to make the best recommendations that we can. I personally would have read this case as a small intestinal mechanical obstruction. I personally do not have a high level of concern for a linear foreign body. And you can see here too, the radiologist is even saying like, you can do an ultrasound to definitively rule out the linear foreign body. And I think also, normally we're talking about doing gastrotomies or small intestinal enterotomies. But in this case, because the material is kind of anchored in the stomach and we can see it going in the proximal duodenum, it's possible it could be pulled back into the stomach with a gastrotomy.
Amazing.
All
I
right.
just gonna very quickly, Kathleen mentioned that we are well informed on the outcomes of many of these cases, and that's again because of a really amazing tool and feature in Radimal is that the specialists are able to request follow-up from clinical teams like yourself as they're reading these cases, and then you're able to share that information with our teams, and that allows us to again have a greater conversation loop around cases. And our specialists are always interested in the outcomes, as you can see. So thank you.
Yes.
Let's keep going.
Yeah, thank you, Kathleen. She's correct. As a radiologist, we can kind of press a little button and it asks for follow-up, because there's nothing I enjoy more than, getting feedback on the cases I've read, both ones where, like everything was perfect or ones where, maybe I missed the mark. It's a learning opportunity for me as well. And so, yes, those are really, it's valuable feedback for all of our radiologists. We appreciate you giving us that feedback for cases. All right. Next up is Mocha, 4-year-old. Again, lethargy, loss of appetite, vomiting. All right. Same deal. I want to try to at least get us through one more after this. So if we can, certainly I want to give everyone time to think and ask questions, but I also want to make sure we just can cover as many cases as possible.
I'm seeing many A's, big old bladder, a B, ultrasound, CC.
All right. Let's start with the AI report. So we didn't need to include the thorax for the purposes of this lecture. We're going to ignore the hepatomegaly. Um, and we're going to look at this gastric distension. So interestingly, this AI generated report is not identifying a mechanical obstruction or a linear foreign body. It's identifying gastric distension. So let's see what we think. All right, same approach. Is there stuff in the stomach? In this case, the stomach is massive. So this whole thing here is all stomach. This is the left lateral, so this is the gas-filled pylorus. This whole thing here is stomach. This whole thing is stomach. This is fundus pylorus with fluid because it's the right lateral. All right. Do we see two populations of bowel? All of these are fluid filled slash collapsed. They are normal in size. So if I stop there, then my question for myself is, in a cat, this stomach, I would say, is severely distended. That is very abnormal, even for a dog, but especially in a cat. Anytime I see a stomach this huge, right off the bat, I'm like, there has got to be something causing an obstruction. So when I see a stomach this big, I'm going to take a closer look and see what I can find. So I'm going to kind of just continue to look around. I've got colon here. Something weird is sort of happening here. I'm not really sure. I'm going to come over to the VD. I don't know where colon is down here. I'm guessing it's here. And I think this is colon. And then I'm not sure if this is duodenum. Like this looks bigger than these. And if this is colon, then that can't be colon. And then I'm going to come over to the left lateral. Here's colon. I'm not sure where it goes. As we talked about on the last case, the pylorus is going to come out here and be kind of right in the middle here. And when I follow that, I see a weird opacity here. And if I go back to the right lateral, I sort of see that same opacity here. I actually don't see it on the VD. And so again, I know we covered this. Take 3 views, give yourself another chance to find the abnormality. And so I think we have a foreign body here. The question is it in the colon or is it in the small intestine? So on this view, I think it's superimposed at least with the colon. I still am not entirely sure where it is here. On this left lateral, duodenum's coming here. It's a little bit tricky to tell. It's certainly over the plane of the duodenum, but it's also over the plane of this, which could be colon. And then also we have this that is distended. And so this is another dilemma that we have, right? Like this is real life. I'm going to get this case. You're telling me it's vomiting. And I'm looking at this saying, like, okay, I think that there is a rectangular foreign body. And I just want to show you what that foreign body looks like. So this is the, oops, excuse me. This is this image, this left lateral. We're going to blow it up. So I just want you to look at this foreign body. Here it is. There definitely is a foreign body. I'm just not sure if it's in the small intestine. Again, here's duodenum right here. Oh, and here I think is colon. So I now have to make a decision, right? Like, is this cat going to go to surgery or are we going to send it for ultrasound, repeat rads, etc.? When you have a stomach that huge, I would put my money on this being in the small intestine. Additionally, we have this, which is probably going to be duodenum just based on the appearance. Like no other intestinal segment is going to be that cranial and lateral that is too big. And so I'm going to use all of these findings together to say that most likely this cat has a proximal duodenal foreign body and has a secondary functional ileus of the stomach. Like that's why the stomach is so distended. If you're not sure, you can stat this out to the radiologist. You can refer this for ultrasound. Again, we're not worried about a linear foreign body, so you could medically manage this cat, see how he does 6 hours, 8 hours. My guess is this foreign body is not going anywhere. You can see it's facing perpendicular to the axis of the small intestine. And so this is another one that, as a radiologist with 10 years under my belt, I would feel comfortable sending it to surgery. The points I want to drive home to you are not like you should be able to look at this and send it to surgery. The point I want to drive home is that this stomach is massively distended. That should trigger you that something is going on here and should make you think more critically about the foreign body being in the small intestine. We're going to go ahead and look at the report. I happen to write this one as well. You can see that on the Radimal reports, we're able to kind of draw arrows so that you're able to see exactly what we're looking at. And so I said the stomach is severely distended with a large amount of gas and fluid. The descending duodenum is moderately distended. And again, that is this segment right here. At the distal aspect of the descending duodenum, there's a focal, faintly mineralized rectangular body. All the other small intestines are normal. So that is our two populations of bowel. We've got all of these bowel here that are small and one that is distended. If you think back to the last case, we had a foreign body and we were like, you know what, maybe we could sit on this. This foreign body to me is different. If you feel comfortable seeing this foreign body, the stomach is so huge, that's going to push me to surgery. And so like these kind of nuances are what make these cases so difficult. It's not just like, do you see the foreign body? It's, is there a foreign body that's visible? Where is it? Are you sure it's in the intestine? What are the secondary signs like? And so this is just a good example of the secondary signs of gastric distension pushing you to go into surgery. Any questions about this one?
I have 3 questions for you, Andrew.
Yes.
First question, outflow obstruction, question mark.
So technically for it to be an outflow obstruction, it would need to be like in the most proximal aspect of the duodenum. This is more like descending. I don't know exactly where it is here, but my guess is maybe here-ish. And so outflow, technically no. Clinically, does it matter? No. It's in the duodenum. It's causing an obstruction of the outflow of the duodenum and therefore the stomach. But like technically, it is not an outflow obstruction, if that makes sense.
Thank you. Next question, what about the pneumocologram? 2 in a day. I'm
Yep.
getting good at that one.
So that's a great question. We should have talked about this sooner. So a pneumocolonogram is where if you're not sure if something is in the small intestine or the large intestine, you're going to put a red rubber up the rectum and the colon and inject air. So in this case, this actually would be a good one to do it, right? Because I was saying like, is it duodenum? Is it colon? I'm not really sure. The only reason in this case I might not is I don't know if you've ever tried to do a pneumoclonogram in a cat. It is extremely challenging because they just don't tolerate it. If this were a dog, 100%, I think that would be a great idea. You'd have to get the red rubber past this fecal material a little bit. But that is a really great suggestion of something you can do in clinic, very low risk. Again, if you're not sure how to do it, get the biggest red rubber you have, put it in the colon as far as you can get it, and you do, I think it's 10 to 15 mils of air per kilo. And so if it's a big dog, you're going to be pumping like 20, 60 cc syringes of air in. You don't have to worry, like you're not going to perf the intestines. It'll just come out the rectum as gas. And so you're going to do that before each image and then retake them, and that'll help outline the colon. So, yes, great advice. I don't highly recommend it in a cat.
Few more questions. Two involving the small intestines. Are the small intestines considered bunched up? And does it matter that all the intestines are on the right side of the VD view?
That's something we hear commonly, that all the intestines are like in one spot. Sometimes that's just how they are. Like if you think about going into surgery to do, like a spay or something, like the intestines are very highly movable and I don't know, slippery, says the radiologist. And so I think to some degree it's that the stomach is so big, it's pushing things over. So sometimes we just see that. That's okay. And the first question about I'm sorry, Madison, can you repeat the first part of
Oh,
it?
my pleasure. Are the small intestines considered bunched up?
Thank you. So when someone to me says bunched, I think that means plicated. If you're saying are they bunched, like are they just in this area? Yes, that's okay. If you're asking are they plicated, I would say no because there's no angular gas opacities. There's no comma shape, there's no paisley shape, there's no plication. Even though like if you look at this one, it's a little bit undulant, but it's very mild and we don't have any of those secondary signs, no comma shaped, no paisley. So not plicated. And the bunching, quote unquote, of them being in one area does not bother me.
Thank you. Curiosity if we knew what this was. Pellet, shaped hairball, Christmas bell. Any curiosity on that? Yeah.
I honestly cannot remember what this one was. If I'm gonna guess, I'm gonna say some sort of eraser or a pen cap or something like that, but I cannot recall what this one is.
And then our last question is, without the stomach distension, would you be comfortable calling it in foreign body? I'm positive I've read that foreign body as summation involving SI and colon.
Good question. So if the stomach was not distended, I would not feel comfortable sending this patient to surgery. Great point. And that's where all these secondary signs are so important. If all I had was this, these images without the gastric distension, I would not feel comfortable saying whether this was in colon or small intestine. I would sit on this case or ultrasound this case and repeat imaging. Um, Absolutely. Time for one more.
Let's do it.
All right. This is Osirix. You know what? We're going to do the other one. Okay. Tatters, 14-year-old toy poodle vomiting. All right. So our last case, we'll try to get through this one in a few minutes. If you have to drop out, we totally understand and we appreciate you joining. Hopefully you'll at least stay to find out the answer before you head on to your evening festivities.
Andrew, there was a question I might not have understood. What does paisley mean?
Oh, um, so if you, I don't know how to, if you think of like a turtleneck that women used to wear in like the 70s, it has this like paisley pattern. Google paisley. It's like a pattern that was on like, I don't know, curtains or turtlenecks or things like that. But Google it and you'll see it's these comma-shaped patterns. And so that sort of gas opacity is what we're talking about.
Thank you, Mary Cole. Yes, comforters and bandanas. Bandanas is, I think, a good one. Okay,
Yes,
we are
definitely.
seeing,
Oh, perfect. Way better than the turtleneck.
let me totally hear you. We're seeing many C's, some B's. Also, just wanted to point out to everyone, if anyone needs to leave, we are going to send a recording of this webinar, so you'll be able to see the rest, wanting to be conscious of everyone's time. Thank you so much. Lot of C's, linear GI perforation. We are going to come back to the signalment and history for this patient. We're just looking at the RADs to start. Thank you so much. Oh, excuse me. There you go.
14-year-old vomiting.
There you go. C, a lot of C's. Free fluid, poor serosal detail, mid-abdomen, something in stomach, question mark? C.
All right, let's take a look. So AI, we're going to go quickly. Gastric material, small intestinal mechanical obstruction. Let's see what we think. Okay, is there gastric material? Yes, I can see it here on this left lateral projection, right? The left lateral is going to show me this gastric material perfectly. So right off the bat, I have concerns. Two, are there two populations of bowel? I measured these ahead of time. So if I measure this one, and let me just pull up the pen. Don't forget, we need to measure from here to here. We are not just measuring that because we have to include the fluid that's in the segment. So if you measure from here to here and compare that from here to here, it was about 2.3. So we have some big intestine. The next question is, do we have some normal intestine, right? Because it has to be two populations of bowel. And so I'm just kind of going to look around. These all look pretty big here. This is colon. This little guy, I think, is kind of smaller. Let's look over here. Here's a good one that I feel comfortable saying is small intestine and is not distended. So again, all of these look pretty big. Here's one that looks pretty normal in size. So again, I'm worried that there is a small intestinal mechanical obstruction. And then I want to go back and look at some of these gas opacities. So some of these are starting to look a little bit comma shaped, right? We've got this one that looks like a U. We've got this one that's starting to be a comma. These all look oval, round, oval. And then we also have something here. I'm not sure what is happening here. Like, is this something textured? This is definitely small intestine. I see it here also. And so in my mind, I'm like, okay, this is a vomiting dog. At a minimum, I know we have gastric material. Here again is the duodenum coming out. This is gas filled, looks normal. Again, left lateral, great to see stuff in the pylorus and the duodenum. I have a high level of concern for a small intestinal mechanical obstruction because I have two populations of bowel. This may be a foreign body, I'm not sure. And then I also have questions about could this be a linear foreign body because we're starting to get some comma-shaped gas opacities like these. And so this kind of puts all the cases together, which is that sometimes you can have both. You can have foreign bodies, and as the intestine try to get rid of them, they create plication, especially when they're anchored in the stomach like this on the left lateral. Anytime I have a vomiting dog with stuff anchored in the stomach, I'm always going to be worried about the possibility of a linear foreign body. Um, and so, if any of those were your concerns, whether it was the linear foreign body part or the mechanical obstruction part, those are going to need to go to surgery. And so we can see the conclusion, anchored pyloric, likely foreign material with small intestinal distension and concern for plication. And so it really only like happens to be that this radiologist who read it and myself agree. Again, if you gave this to multiple radiologists, some people would only read this as mechanical obstruction or maybe would be more definitive about a linear foreign body. But regardless, I have concerns about both. And no matter which one I have concerns about, this patient should go to surgery. Any questions?
Colon is very agitated, colitis.
Colon is hard to see. So here's colon here. I think it comes up here. It's pretty collapsed. There I don't feel strongly about colitis. Usually I want to see the colon be more fluid distended and bigger. I don't feel super strongly about it. And even if this dog does have colitis, it still needs to go to surgery. If it weren't, you were going to medically manage it anyway. But to me, this colon could be seen as normal. I apologize if you
Pancreatitis?
hear rustling. My cat has decided to jump into a box at this exact moment. Pancreatitis, good question. So here is the stomach. Pancreas is going to live. Madison, are you able to see my mouse right
Yep.
now?
Yes.
Great. Um, oh, here, let me just there we go. Okay. The pancreas is going to live just under the stomach and kind of right limb, body, left limb. Usually you'll see widening of this gastroduodenal angle. I don't see specifically decreased serosal detail right here. So I don't think that there's pancreatitis. I don't think that there's a large volume of effusion either. The serosal detail here is good. If you wanted to make an argument to me that in here the serosal detail is slightly decreased and this patient may have either scant effusion or a little peritonitis, sure, but not a large volume of effusion where we're worried about a perf or something like that. I think someone also had mentioned that they were worried about a pneumoperitoneum. I don't have that concern in this case. The biggest areas to look are right up here by the diaphragm, or if you see any gas opacities that aren't definitively in a intestinal segment. In this case, I think they are all within intestinal segments, so I don't have any concern about free gas in the abdomen either.
Could this be a mass at the fuzzy area in the ventral abdomen?
Could this be a mass? Yeah, so that's a good question. We're not always able to say whether it's a foreign body or a mass, and particularly in this patient who's 14, I think that's a good thing to kind of have on our radar. I guess the only thing that would make me think less likely is it looks somewhat textured, which would be uncommon for a mass, but absolutely, really anytime you see a mechanical obstruction, if you don't see the foreign body, it could be a mass. And actually, real quick before we end, I just want to make that point because we just haven't happened to come across that yet. If you see a mechanical obstruction or a linear foreign body, you do not have to see the offending cause. So I will call a mechanical obstruction if there's two populations of bowel, even if I do not see the foreign body at all. You do not have to see the foreign body whatsoever to call radiographically a mechanical obstruction. And I would absolutely still send those patients to surgery, even if I can't see the foreign body.
Is the corrugated region caudoventrally on the right lateral of loop of SI, excuse me.
Yes, so this is definitely small intestine. I agree. It looks a little like undulant. This might be an area of a little bit of plication, although it doesn't have an angular gas opacity, but I agree it looks a little undulant. Colon generally is going to come across, so it's going to be descending, transverse, ascending, cecum. Descending, transverse, I don't know where ascending is. I'm guessing this is cecum. Anything this ventral, always going to be small intestine. You will never have colon along the ventral abdomen. Too ventral.
Would you say the intestinal loops appear thickened?
So they are distended. You can't say they're thickened. On radiographs, fluid and soft tissue opacity have the same opacity. And so this segment is distended. But if you were to ultrasound it, my guess is not that the wall would be thickened. My guess is that the wall would be normal and it's filled with gas and fluid. And that's why it's distended. So, yes, they are distended, but I don't think it is the wall specifically that is thickened. That being said, you don't you cannot make that comment either way. I guess times where we worry about that more would be like in an old cat who has all of their small intestines that are mildly distended. Then I start wondering, like, could this cat have chronic inflammatory bowel disease or round cell neoplasia? But those are more like just mild diffuse distension of the bowel, then I start to wonder, is it possible that there's wall thickening, but you need an ultrasound to ultimately make that call.
When you say, quote, two populations, do you mean one normal and one distended?
Exactly. Yep. One normal, one distended. That does not mean one gas filled and one collapsed. It only means one normal and one big. The big could be gas, it could be fluid, it could be foreign material, but it has to be one normal, one big. And actually, there we go. Um, so just to drive this point home, if we're talking about a small intestinal mechanical obstruction, when we're talking about dogs, we're going to measure those intestine. If they're greater than 2 times the height of L5, based on literature, those patients are most likely going to be obstructed. Technically, they used 1.6 as like the cutoff for normal, but as you get closest to 2, that's when the sensitivity is highest, and that's kind of the number that I use in my mind. If we're talking about cats, we're not going to compare it to L5. We're just going to measure them. Anything greater than 12 millimeters is too big, and you need two populations of bowel, one severely distended. This is a totally separate entity from a linear foreign body where we're going to look for angular gas opacities. Again, we do not have to have distension and check to see if it could be anchored in the pylorus, and we're going to see that most likely on the left lateral.
We are getting so many comments on how incredibly informative and helpful and just
I love
wonderful
that.
this whole session was. Just really wanting to thank you so much, Dr. Weissman, for your expertise and your sharing. And thank you all for all of your questions. It's been really, really fun to do this with all of you and have this engagement. Like I mentioned before, I'll come back on for a moment and say hello again. My name is Madison. Andrew, can we go to one more slide ahead for by any chance? Thank you
Yes.
all again. If you all need any support, please scan that QR code. You will get your first 5 reports free, supported by our community, like Dr. Weissman and some of the other team members that you saw tonight. We will be hopefully hosting another round of case rounds soon. We can't wait to host you all. Also send us any special topics you'd love covered. Thanks for also mentioning that some of the technicians really enjoyed this and the value that this brought to them.
Love
Um,
that.
yeah. Someone wrote, not sure why vet school radiology couldn't be as clear and sensical. So great job, Dr.
Agreed.
Weissman.
Thank
Um,
you.
yes, we do have resources on supporting you on taking best possible RADs. Our specialist team has a private note section so they can be in communication with you, give you tips and tricks. That same also happens with ultrasound. Really exciting that way. We also have support with exotics. So we did cover mostly companion animal, but that doesn't mean that we don't have exotic support from board certified consultations, specialists, excuse me. Um, Someone mentioned, please do a thoracic series on heart versus lung cases. Exotics would be fun. Great. Many people agreed about the vet school radiology courses. Um,
If you guys have topics that you like, heart versus lung, even if you can be more specific, the more I know what you would like to learn about, the easier it is for me to tailor talks that are, based on topics that you guys would like assistance with.
One question that's popped up, do you typically recommend sedation for abdominal x-rays?
I recommend whatever is necessary to get good quality rads. At the clinic I work at, anything greater than 25 kilos or anything that is marked anything other than friendly requires sedation. A lot of it is just, for the comfort of the patient, for the comfort of the technicians. I think it's, just not easy to pull the legs forward, pull the legs back, get them well positioned. And so whatever is necessary, commonly that does involve sedation, yes.
I'm seeing lung patterns, heart failure, please, cardiac and identifying CHF, lung
Mhm.
patterns, geriatric, pneumonia, most common cardiac lung abnormalities, lung patterns, all exclamation points. One other question that popped up, do you have a textbook that you like, love, slash recommend?
Good question. I do. Thrall, but not the Thrall we all used in vet school and like had to slog through. Thrall has a separate textbook. It's called the Atlas of small animal. It's like a quite thin book. I think the cover is like a bluish gray. That has nothing but normals and variants of normal. So that would probably be my top choice. If you're someone who sees a lot of young, like neonates, there's a really great textbook. It's by Colson, Coulson, and Lewis is the last name of the other author. And it has musculoskeletal radiographs of like 4 weeks, 8 weeks, 12 weeks, 16 weeks of all the different body regions. And so that is a really awesome book as well. Those are the two that kind of come to mind the most.
I tried to pop one of those least links that I could find online. Yes, that's correct, Stephanie. Thank you so much. These are all amazing questions, and we will definitely take them all into consideration for next time. Also, as I mentioned before, the recording of this webinar, as well as all webinars that we've hosted, including another incredible one that Dr. Weissman hosted, are all available on our website. So you can access those in any time, come back to this, and share it with team members. Wonderful. Well, thank you all so much for all of your time, staying with us a little extra, spending this spooky week with us. Once again, my name is Madison Alig, and this is Dr. Weissman. If there's anything that we can do to support you, please don't hesitate to reach out to us. Scan that QR code. Our team members will be in touch with you and excited to support your patient care.
Thank you so much, everyone.
Thank you. Have a wonderful evening. Good night.